Well, hello everyone, and welcome to You Can't Build That Code. I am Mandi Berg,
I am Carey Mead.
and again, thank you for joining us. So, today we're going to talk about essentially scenarios where you can build situations and where you cannot, and essentially like what you need in order to be able to bill said items and/or timed codes. So, I figured we kind of start with DME since that seems to be one of the largest schemes that is always on OIG's radar. It seems to be on all of the insurance plans' radars, and rightfully so, because it is a common scheme and a common, easily abused items. Wouldn't you agree?
Absolutely. One of the most costly areas that we deal with is DME. It's routine, it's schemes that have been around for numerous years, but their codings tend to change. So, one of the things that a pitfall that you may want to avoid is not knowing the documentation requirements. CMS does an amazing job of laying out the groundwork of what's part of a standard documentation that should be present for each of your DME categories. What do you think about what's the components, Mandi, that usually are missing?
So frequently, what is missing is the proof of delivery. That is the most common item that we're noticing in a lot of our items or in our audits. Additionally, the order, right? Um, or at least some sort of reason, the documentation as to what is being prescribed or what is being handed out. The most common item that we're seeing in our audits are the 99 codes, so the knock codes. For example, E1399. Um, Providers are billing those so frequently, but what is actually being dispensed has an actual DME item that they should be using instead. So, Carrie, you want to kind of run through why that's inappropriate?
Well, first of all, we need to be able to apply the appropriate CPT code. The plans need to be vigilant in not providing codes to providers during the authorization process. There should be a way for us to validate that what was being dispensed is actually appropriately coded. It actually is something we can recreate with the manufacturer. We can verify that that's the same make and model. So a lot of times we also need to look at your invoices, or it can be easily depicted on that proof of delivery so it's clear that what's being delivered is what's being billed, so that there are not times where there might be results of recovery just simply based on an inappropriate code. And one thing I would strongly caution is having a clinician pick a code based on a description only. There are numerous requirements that having the guidance of a certified professional coder is always key in ensuring that you're going to maintain the proper payment for services rendered.
Absolutely. And additionally, with DME items, a lot of them have an actual shelf life or life expectancy. And what we find a lot of times is that instead of billing for the replacement or a repair, they're just outright billing for a whole new item, which is also completely inappropriate.
Absolutely. CMS has a reasonable useful lifetime of most equipment of 5 years. During that time frame, there might be repairs, there might be replacements needed, but certainly turning around and billing for the same equipment on a yearly basis or even more is an opportunity for systematic editing at the plan level to ensure that they're being protected from those vulnerabilities as well.
That's a really
There's
good point.
also there's also so many opportunities to avoid uh, improper orders, just things like signature, who's ordering, but most importantly, your medical records need to be reminiscent of ongoing medical need. A lot of times, patients may experience times in a hospital while you're billing a particular capped rental. So, if those capped rental payments are overlapping an inpatient stay, there should be an appropriate break in service, but that should also be reflected in your records. And records typically, well, are mandated by CMS to be updated within the last calendar year. to demonstrate the ongoing medical necessity and need of that item, that the patient's actually using it. It also needs to be reminiscent of auto-shipped supplies. We want to see that there's interaction with the patient. We want to see that those needs are demonstrated in those records so that the ordering is the same person as the notes are coming from, so we can see the continuity of care. Suppliers are still absolutely required to show that they are instrumental in the utilization process for the patients so that we maintain that. In 2024, they changed the refill requirements. Those requirements only remove the requirement of verifying supplies on hand. We still have to have an affirmative response from the patient and showing that they want additional supplies so that we're staying within the requirements and we're not excessively billing beyond what's appropriate for that month.
Yeah, so I mean that falls into like the auto shipments. Auto shipments are not appropriate. So if you see them happening, that's definitely something that you should be paying attention to in your data, and it's something that is worth auditing.
Absolutely. Every CMS policy for DME typically does have some indication of medically unlikely editing or NCCI editing limitations set up in a grid. It couldn't be clearer. It's an opportunity for providers to self-audit. It's an opportunity for investigations, but most importantly, it's an opportunity for plans to edit appropriately.
Absolutely. Another way to also pay attention to your data is a lot of times what we have noticed with DME items, especially with things that have MUE and NCCI edits, is unbundling. They will unbundle on separate claims. They might split the amount of units so that they can exceed the MUEs. They will split the items on different claims so they can unbundle the NCCIs, or they like to add modifiers. I know, Carey, you're a big fan of modifiers. Do you kind of want to talk about what modifiers would be the most frequent with DMEs?
DME, one of the biggest ones I don't see is the right and left modifier. It's typically something that indicates if you're doing one or both. I cannot tell you how many times I've actually seen instances where we're seeing prosthetics, orthotics, or shoes billed for right and left automatically for most providers, yet the patient or the recipient was an amputee. So typically, while we sell them, but the documentation needs to be more thorough in explaining the ongoing medical need. There's routine issues, specifically if you look at the nebulizer policy for CMS, they structure out if you have a large or a small volume nebulizer, or if it's a compressor, pneumatic, or ultrasonic. Each of these have specific supplies related that can be billed. I've seen instances with a nebulizer being billed with 48 feet of oxygen tubing. Obviously, that was a red flag. So there's also kits that are often now used in DME, and CMS has decided that certain components of like an enteral kit for feedings are all inclusive. And so when we see providers billing those individually unbundled, we know that there's a generation of additional payment that is clearly something to look at.
I'm glad that you mentioned the enteral kits. We actually have had several cases where what the patients are receiving are essentially Ensure shakes, and then they aren't they don't have a feeding tube in any way, shape, or form, but they're getting those supply kits to go along with the Ensure shakes. So it's basically a way to just package on additional payments, which is, as you had mentioned, completely inappropriate. So that's something to in your data, right? Additionally, diagnosis codes, right? These are things that you should be paying attention to with your DME items. Are the diagnosis codes appropriate for what are being billed? Any other data mining tools that you might have for people to be looking at?
The biggest thing is the coding structures. In DME across the country, CMS mandates that the MACs utilize a structured same approach in their policies. So it doesn't matter what your location, those references usually are even being published together. So It's easy, it's simple. There's plenty of free references to go to, and you can have a lot of additional guidance that each MAC chooses to publish based on those categories. There's checklists that I would encourage you to review that are thorough in what is required to be present in your documentation. A standard written order alone is something expected to be part of the documentation. Typically, we also see that as part of the prescription, and what we'll often see is many times somebody didn't sign a prescription, or the prescription's coming from somebody completely unrelated to the records. So it really does need to be a thorough overview. One thing I would strongly caution, do not bring large amounts of equipment to a doctor's office and drop it off, letting the doctor make the choice as to how those items will be dispensed. You as a supplier are always responsible for ensuring the coverage criteria is met, that the documentation components are present in order to retain payments for services rendered.
One of the terms that I've always heard you kind of like reference before is a walking mummy. Can you kind of describe what the walking mummy means in the term of DME world?
In DME world, this has been a scheme for close to 30 years or more. When we see either one supplier or multiple, usually two, it's usually a list sharing scheme where you start putting the claims data together and you can see a clear picture of a mummy starting with the neck or head area, and there are prosthetics literally or orthotics, excuse me, all over the body, all the way down to the feet or ankles. So you're literally walking as if you are a mummy because you would not be able to move properly if you really to wear all of these items. Furthermore, you'll see them billing them repetitively over and over for maybe every 6 months or even multiple years. So when we think we see a trend that's just a back brace, look further. Usually, if you run some overlapping data on your members to see if you have a link, you're going to be able to portray a really beautiful case. And those are not just red flags, they're usually good criminal referrals.
I love that. Thank you. Something else to also pay attention to with these DME providers is a lot of these facilities check the address, right? I know we had a referral from a plan most recently where the address doesn't even exist anymore, but they're still billing for services. This happens so frequently, not just for DME providers, but for laboratories, for physician offices, right? Like they bill as if they have a physical location, but they're actually billing and performing allegedly out of their homes. Simple Google search is very beneficial. Any additional thoughts on that?
Yeah, one really big red flag, and someone asked me once, how do you know in the documentation that you're looking at one of these particular scenarios, like a walking mummy or a different ring? And one of the biggest red flags I see is a prescription coming, usually indicating a P.O. box. And if you look at the address, it goes back to an apartment building where someone is just getting some sort of reimbursement for signing prescriptions. The documentation is a completely unrelated physician or ordering and doesn't necessarily always even align with a primary care provider or specialty. They might be somebody completely unrelated. We have a lot of pain management, or I've seen nurse practitioners that are completely in a different state submitting these orders, and we realize there's a larger issue. So pulling apart those records and seeing can you see a trend or pattern of where somebody's been whiting out names and just adding names? There's easily ways that you can see that there's been inappropriate amendments to the documentation that don't follow CMS guidelines as far as how we outline those changes or what's appropriate in the industry for amendments. There needs to be a trail. And so when we see that there's a lack of evidence, the other thing I caution strongly is fluff. And what I mean by fluff is really unnecessary forms and documentation that do not support the coverage of the services, but really just add to the stack of paper that was sent in.
All good pieces of information. So essentially, stated, if you fail to meet the DME documentation requirements, your claim should be rejected, right? If you don't have proof of delivery, can't pay for the service, you can't confirm it was done, then the claim gets rejected.
First, and the other thing to caution is plans need to be very vigilant in the authorization process. You should be knowing that there should not be a code handed to providers. They are responsible for providing the accurate code for what's being dispensed. But further, an authorization is simply an agreement to bill a plan. It does not imply coverage or payment.
Absolutely. So another round of codes that are on all of the plans, especially the OIG work plans this year, are physical therapy codes, chronic care management codes, transitional care management codes, remote patient monitoring. And something that all of these codes have in common is a timed component. And not just timed component, but they have very clear cut documentation requirements as well. And so that seems to be like the common theme today is documentation. And documentation is actually the common theme in healthcare in general, right? If it's not documented, it didn't happen. But essentially, with timed components, if your time doesn't prove that you spent that amount of time on the service, essentially you can't bill for it anyway. And a lower level service and or the number of units that you're trying to bill for can't be billed. So I guess we could kind of start with physical therapy. Carey, what are your thoughts or recommendations with physical therapy audits?
The elements that and the exercises or the different treatments that are being performed need to be specified. What is the plan and desired outcome? How is the patient's progress making that outcome? But the biggest thing I see is the excessive times being billed. There are NCCI edits tied to each of these physical therapy codes that really, if you're going to exceed them, it should be rare. It shouldn't be routine. And if we're seeing those trends, we're certainly going to look at them. Additionally, at the records that's supplied, most of the time we see very, very minimal, only EMR generated type scenarios that do not substantiate the care being built. There's even beyond just physical therapy, other timed codes. There may be a time you have to have start, stop, you have to have some quantity designated in there, but further, you have to have enough documentation that would warrant 45 minutes to an hour of care or whatever's being billed. But also remember, CMS has an 8-minute rule. If you did not designate the 8-minute rule or 8 minutes worth of care within your documentation, you will get 1 unit if you're lucky.
Absolutely. And that is the big focus or one of the big focus for the OIG work plans this year for that exact reason. Physical therapy, occupational therapy, speech therapy, they all have timed code components. And there is such an abuse in these services. I cannot tell you the number of times that we see providers that are billing 4 units or more of services. I don't know about you, but I'm not going to sit in a doctor's office or a physical therapist's office for an hour or more a time per, a day to get a service done. So when you're data mining, you want to focus on these services uh, for multiple units, right? Multiple codes. How long are they there? If you've got patients that are spending hours upon hours or more, it's a really good idea to get a sample of those services and see, especially when they're timed components and they have non-timed services being billed on the same day. Are they all actually being done? And is the patient really there? Like, is it supported?
I've had instances with nutrition therapy and other types of therapy where we actually asked for their schedule for the day, and you will see that there's an attempt to make it look like they saw patients from 7 in the morning until 10 o'clock at night. But the documentation does not come close to validating that. The point of most of these therapies is to teach someone how to be effective for themselves. And what we don't see is those elements demonstrated in the records showing plan of care progress and execution or an assessment of improvement. what we see is a routine abuse of the programs that are just a repetitive, ongoing claims coming for the same things for excessive amounts that aren't warranted.
Absolutely. So another thing to focus on too is, and I know we kind of talk about it, the term impossible days. I know it's kind of a general term, but when you have a provider that has such high volumes of units on a particular date of service, that's kind of a good idea to focus your data on those as well. Um, Thoughts on that as well, Carey?
It can be applied across numerous categories. It's something we might see in office visits. It could be something we see in home health care. It's a questionable amount. If we're having patients being billed for more than 24 hours a day by an entity, by anyone, it is certainly reasonable to look at it further. There may be instances of NPI misuse. There might be instances of multiple providers rendering care under one provider number. But to look at it past just the documentation, we're looking at it on a data mining aspect, and it gives us really a reason to look further. It usually is a good guide. There might be justifiable reasons for what we're seeing, but more often than not, it's a red flag in our data.
Absolutely. And also take into consideration when you see those kind of numbers, especially when they're greater than even 12 hours in a day, how many insurance plans does that provider see? Take into consideration that that insurance or that provider is not seeing just your members on that singular data service. So it may or may not be an impossible day, but it's worth kind of looking into that and kind of building accordingly. So
Well,
we,
and
mhm, go ahead.
there's even some time codes that aren't 15-minute increments.
Correct.
There is anything from anesthesia that's 15 minutes at a time typically, but we have remote patient monitoring and nerve testing for surgical purposes. That is something that's billed an hour at a time if you're billing the incorrect code. So it's something to realize that there may be multiple surgical suites happening at one time, and each of these patients likely have a different insurance. So what CMS put in is the prohibition of coverage for those types of scenarios unless the person that's remotely monitoring is designated specifically for that patient for the payer. The other thing to consider is there has to be documentation showing when they walked away or when they were moving on to a different patient so that that time spent is not covered. So it's more integral than just a time spent within the documentation. It might be additional coverage criteria.
And I love that. That's a perfect segue to remote patient monitoring, chronic care management, transitional care management. As you mentioned, they have timed components, but they have clear cut criteria by CMS. And CMS actually has flyers and pamphlets out there that give you the clear cut criteria on who can bill, how can you bill it, what you have to have documented. So, I mean, it's very useful information. Additionally, they have within those pamphlets of information what codes can you be billing with these services and what codes can you not. So, in addition to paying attention to that, you also need to know what are your policies, what are your rules, and what are your plan's guidelines.
Absolutely. I mean, we all can look at this from a removed space and say remote patient monitoring is really for us to be empowered to help assist providers to look further at different conditions. But the problem is a lot of clinicians tend to look at the codes description only and apply them. They don't realize that there's actual coding criteria that goes with it that you have to meet for the coverage and the payment to be appropriate. And that's one of the biggest downfalls is always seeking that certified professional coder guidance or appropriate training because peer groups aren't always the best resource for guidance in those situations.
Absolutely. So, again, it comes down to if it's not documented, it didn't happen.
Didn't
Uh,
happen.
Timed components, it needs to be documented. So, it absolutely comes down to documentation, documentation, documentation. When you're performing these audits, you need to make sure that you're looking at not just the data, but what do the records tell you?
One of the interesting things is not that long ago, I had a biller who was defending her position on a recovery we were doing on an audit that did not show that the services were supported. She said to me, only the doctor and the patient know what happens behind closed doors. That should never, ever be the case. When we're rendering services, you are expected to document every single thing that occurred so that the appropriate code can be billed. That was a telltale sign that she was not a coder. And so it really is an opportunity to ensure if it's not documented, it didn't happen. And we're not saying you didn't render care, you did not adequately represent it in your records.
So essentially, what are the recommendations, right? If it's not documented and it didn't happen, what are the options that you have? So you can deny the service as unsupported, or you can give credit for a lower level service.
Absolutely. There might be opportunities to downcode. And that's one of the things is you can't build a higher level code because the description seems to meet the criteria you're looking for. The lower level code might be demonstrated in your records based on different complexities or comorbidities or different things that are being addressed. So you want to make sure we can certainly offer you a credit for the services you did if we are able to do that.
And one of the things that we have found in doing that is it brings the provider to the table, but additionally, it shows I'm so sorry, my brain just doesn't want to get the words, but it's a good faith, right? It's good
Yep.
faith. We're showing that we're giving credit for a service that they actually did perform. And it's about opening the lines of communication between us and the provider. So again, it's about knowing what your plan's rules are and what the plan is agreeable to doing. But those are essentially the options that you can do as far as performing the audit and taking back the service.
There's always the option to, we always want to reward what you're doing correctly or what providers are doing correctly, bringing them to the table, ensuring the education is done so that we don't continue to see the pattern. The biggest thing you can always look at if you see this happening over and over and we aren't changing behavior, the corrective action plan isn't a bad idea because there needs to be accountability. The provider is responsible for demonstrating what happened on the claim form accurately under the False Claims Act. There is responsibilities to be considered that the plan needs to execute correctly as well. So then when the questions come by the state or the federal or whatever entity is regulation for that situation, you have your bases covered. But if you choose to credit because there was warranted creditable items, then you're able to show why you were able to come to an agreement.
Excellent information. Well, I see that we're coming up on time, so we will go ahead and open the floor up for questions. But before we do so, we want to remind everybody to join us every month for all of our various webinars. And if you ever have questions, don't ever hesitate to reach out to us.
It's a great day at Advise. Let us know if you have any questions.
It is a great day at Advise. And as always, thank you for joining us.
Thank you.